Well, I just want to say hello. I'm doing an awful lot of things this week for World Thrombosis Day, and it's a real pleasure to start off with a patient session because we're doing it all for you, really. So let's get going. Real basic slide to start with. What is thrombosis? So we know that 1 in 4 people who die will die of a thrombosis, and within that, we can have people who die because they have a blood clot in their heart attack, or blood clot in their brain, stroke, or the neglected area of deep vein thrombosis, so blood clots in the deep veins of the calves and thighs that can break off and block the blood supply in the lung, known as a pulmonary embolism. And when we look at the global figures, heart attacks are number 1, stroke are number 2, and we're not sure about the numbers about pulmonary emboli, but they're definitely number 3. So we've had a number of questions pre-submitted, and we're going to go through them, and I will try and explain as much as I can. And if I'm not explaining well, please, would you leave a question for me? So these are the questions. Has there been any research in people who've presented with blood clots to see if they have an underlying form of thrombophilia? And I think this is probably about COVID, but if we just look at people before COVID and say that when we look at blood clots, and when I say blood clot, I'm talking about DVT and pulmonary emboli, then we know that 60% of them, so the bulk of them, are provoked, and the commonest cause is hospital admission. It's that perfect recipe. You go into hospital, you're not very well, not very well, your blood gets sticky, and then you lie around, so you're immobile, so you have reduced blood flow in the leg veins. And if you have surgery, the surgeon can damage the lining of the blood vessel. So those 3 things increase the risk of clots. And then we've got things like the pill, the tablet form of hormone replacement therapy, but not the patch form, and cancer, and all the other things that provoke. But when people have an unprovoked event, so you can't really find anything when you talk to them, they haven't been on a long haul flight, they haven't been sitting for days working for an exam or anything like that, then we would look to see if they had an underlying sticky blood. And I use the term thrombophilia interchangeably with sticky blood because that's really what we're looking for. And we really only look for inherited causes if someone's got a strong family history, but we always look in everybody with unprovoked for antiphospholipid antibodies. Now, the problem with thrombophilia testing is really disappointing. So if there are 100 of you in this room who'd all had a clot and had a really strong family history of having had clots, only about 50% of them would we find some underlying genetic change. And that's because we don't know enough about clotting. So the other 50%, clearly there is a genetic factor, but we can't put a label on it. But finding an underlying thrombophilia doesn't mean to say that you need long-term anticoagulation. So thrombophilias go from, wow, how sticky is your blood? And that really is antithrombin deficiency, to factor V Leiden. So antithrombin deficiency, really rare, less than 1 in 5,000. Factor V Leiden in the white population is present in about 5 to 10%. And it makes you clot a little bit more. But if you have a clot, you haven't got a higher risk of having another clot with factor V Leiden. And I think that with factor V Leiden, it just makes people worried. And yet, if you have factor V Leiden, you've only got a tiny chance of having a clot. 95% of people who have factor V Leiden never have a clot in their lifetime. Then, so that if we apply this question to COVID, do we look if they have a blood clot with COVID, if they have an underlying form of thrombophilia? No, because it's COVID. It's COVID. If they've got COVID pneumonia, the blood is really sticky. That's more than enough cause to form clots. Okay, next, I was diagnosed with a blood clot and have a strong family history of clots. I was advised to stay on blood thinners for life. Why? Well, that's the tantalizing question, because we don't really know if this individual had a provoked event, and I presume they didn't. They had an unprovoked event and it was quite serious. And we know that if you've had an unprovoked event, you've got quite a high risk of having another clot later. So we would leave you on long-term blood thinners. And whether or not you have a strong family history is irrelevant. It's the fact that it's unprovoked. So it's just come out of the blue, and there's about a 30% chance of having another one in the next 5 years. Sorry to bamboozle you with all these stats. Next, are there links between asthma and VTE? Well, no, I'm not aware of any, but I am aware that quite a lot of people who have pulmonary emboli can present with a bit of shortness of breath that gradually gets worse, and the doctor may mistake those symptoms as asthma. But there are no real links between asthma and blood clots. Okay, I'm going to move on.
Beverley, can I just interject, because a question's come in, and they've asked whether there's a link between gingivitis on your gums and pulmonary embolism. Could you perhaps just run through a few things that are most common risk factors?
Okay, well, so gingivitis is a really fascinating one, because we know if you've got chronic inflammation in your mouth, or you've got chronic inflammation anywhere, for example, you've got lupus and you have a lot of flares, then your blood is more sticky. So when inflammation occurs, blood is more sticky. So with gingivitis, we know if you've got long-term gingivitis, you've got a higher risk of heart attack and stroke, and probably pulmonary emboli. They haven't really looked at that association. So it's a good reason to go to the dentist regularly. So, Jo, what was your question? What are the other risk factors for clots?
Well, yes, somebody else had come in and said, would there be a greater risk if factor V Leiden is homozygous?
Homozygous.
Homozygous.
Okay, so factor V Leiden on its own, so that's one gene defect, that's called heterozygous. It increases your risk of having clots somewhere between 5 and 8-fold, but your background risk is really, really low. So it's just making it a little bit more sticky. But there's a benefit to it too, because you have slightly less bleeding if somebody was to stab you or something like that. Hopefully that never happens. But you can get a double dose. So a double dose of factor V Leiden is known as homozygous, and that is much stickier blood. And the risk of having clots is about 80 times the background risk, so makes the blood much stickier. So we are on the lookout for people who have a double dose of factor V Leiden.
Thank you.
Anything else?
No, that's perfect. Thank you very much. Thank you.
There's a lot of information. Okay, COVID and blood clots. This is the question that we get asked again and again. Is there any needs for anticoagulation, prophylactic or therapeutic, when infected with COVID-19 but not hospitalized, in those who've had previous blood clots or some level of thrombophilia, or not currently on anticoagulants? So I can't think how many times I've been asked this question by email, Reddit, Facebook. So let's do this and get it sorted. So when you have COVID, we know that the blood gets very, very sticky when you have COVID pneumonia. COVID pneumonia. But when the average person gets COVID, they don't feel very well. They might lose their sense of smell, they might have headaches, muscle aches, a bit like flu. And 95% of people get better. And that group don't seem to get the sticky blood problem. It's when you get the pneumonia, so your lungs are affected and you require admission to hospital because you need oxygen, because your lungs are so badly damaged, you're very breathless and you need extra oxygen. In the worst case scenario, ventilation. Those patients have sticky blood. Now, that group tend to be male and older and overweight and have other cardiovascular risk factors. So this isn't young people who happen to have falsified Leiden or anything like that. So the risk of getting COVID pneumonia is low in younger people. So that's really COVID. So when we look at COVID, we are seeing blood clots in those who are in hospital. And there are now a lot of guidelines saying if you come to hospital with COVID, then you must have a small dose of an anticoagulant. And that is happening. That is happening in UK hospitals. Just currently writing the guidance for the London hospitals. I know everybody is giving thromboprophylaxis anyway, but we're rewriting them. And NICE are now going to do some proper fresh guidance on this. So this is happening. And in fact, if people get admitted to critical care and they need ventilated, they get put on a bigger dose because they seem to have a higher rate of clots. And we are doing research to find out what is the best dose of anticoagulant in the group of hospitalized patients. So then we've also got now some places where we're treating people at home with oxygen. And all the treatment that we give in hospital, they will get blood thinners. So the thing is, if you do get COVID and you're pretty okay and you haven't got COVID pneumonia, please keep mobile, because what happens if you take off to bed and you're immobile, then obviously you're increasing your risk. So no one really is recommending giving blood thinners out of hospital. The thing is to keep mobile. And we need to do some clinical trials to see whether it might be worthwhile to do that. But at the moment, nobody is giving blood thinners before someone is admitted with COVID. If you're already on blood thinners, that's great. Keep taking them. And when you get to hospital, they may be continued if you do have COVID pneumonia, or they might be switched to heparin injections, depending on how sick somebody is. So what am I trying to do? I'm trying to reassure you that the risk of COVID isn't higher if you have a thrombophilia. Your risk of severe COVID isn't higher. The people who have a high risk of COVID pneumonia are immunosuppressed. Sticky blood is not immunosuppression. Jo, have I missed anything out there?
No, I don't think so. I'm just looking at some of the questions submitted, but no, I think you've covered everything. And we've
Okay. Next, if I have a positive diagnosis for COVID-19, should I contact my doctor? So do you remember when the COVID started, you were told to stay at home, not go to hospital, not go to doctor? I think that most people who are getting COVID phone NHS 111 if you're in the UK. The rules keep changing, so I would follow the current rules. There's no reason for you to contact your doctor if you've got previous thrombosis. Then you might want to contact your hematologist or thrombosis doctor. But I ask my patients to, because I'm interested to see what happens to them, because I'm learning. And I have had many of my thrombophilia patients have COVID and they got better. And none of them have been in hospital with COVID pneumonia. So they all seem to do fine. And I just say, look, keep taking the anticoagulation and keep yourself mobile. Next, thrombophilia and COVID. Here we go again. Would there be any greater risk of thrombosis in somebody with a thrombotic disorder who contracts COVID? And the thing is, if you go into hospital, if you're already on anticoagulants, they'll be continued, or then you may get a higher dose, or you would just get the heparin injections that we'd normally give in hospital. So I'm not clear at this current stage that having a thrombophilia does increase your risk of having thrombosis with COVID. And I suppose the other issue with the COVID thrombosis is that there's two types. So we've got a probably increased rate of deep vein thrombosis and pulmonary embolism, which you would expect in anyone who's sick. But we also are getting what we call immunothrombosis. This is tiny little thrombosis in the lungs because the pneumonia is so bad. And we see that in all different types of pneumonia. So when the lungs start to fail. And at the moment the jury is out, is it slightly more with COVID or is it the same? We're doing some research on this. Okay, what precautions should I take? I presume this is somebody with thrombophilia. Keep yourself mobile, keep yourself well hydrated. If you get COVID, if you get short of breath, get yourself off to be tested for your oxygenation because COVID pneumonia is the worry. And the other thing I need to say about the COVID pneumonia is, my goodness, we've really improved how we manage these patients. So at the start, we weren't sure how to ventilate them, what drugs to give them. So now we know exactly how to ventilate these patients. Instead of pushing hard with lots of oxygen, we push gently. And they do better with that. We make sure they're hydrated. And to start with, I think everyone was thinking we need to run dry, but we've got dexamethasone, which reduces mortality by 1/3, and everybody is getting some form of anticoagulation. So there's also remdesivir, which reduces length of stay. So it's transformed the management of COVID pneumonia. The survival rate has increased dramatically. Right, who normally manages care? I can't see the edge of it. Is that after diagnosis, Jo?
Yes, it is after diagnosis. Yeah.
Okay.
And why this sort of topic has arisen, I think, is actually as a part of a fallout of the pandemic, where especially this year, we've had a lot of questions around being diagnosed, discharged, and then felt as if you're left in limbo because consultations are harder to have sometimes. And so who normally manages it? How do you access it as well, really, and make the most of it, especially in more difficult times as the pandemic has brought?
Okay. So if you have a thrombosis because of COVID, you would go on 3 months anticoagulation. You might get some telephone follow-up from one of the hospital doctors, either in the medical department or from hematology, and they'd stop the anticoagulation after 3 months and probably discharge you because there are no real long-term risks if you go back to normal health. How can I get the most out of a telephone consultation? I always think it's worth writing down all the questions before you have the telephone consultation. I don't know about you, but my mind often goes blank when I go into a meeting with a doctor as a patient. So helpful to ask the type of questions. So I'm on this anticoagulation. How long am I going to continue it for? I'm still breathless. Is that normal? My leg is still swollen. Should I be doing anything else? All that type of question, write it down so you get the best. Would I normally have a follow-up appointment? So if it's a provoked clot, we don't tend to offer up long-term follow-up. You should normally have some contact with the hospital over that 3 months just to check you're taking the anticoagulation, you're getting better, and to arrange a time for you to actually stop taking it. What role can I expect my GP to have in managing my DVT? Well, if it's a hospital one, not very much. And I think you have to remember that when someone's discharged from hospital, the hospital doctor has to talk to the GP. The GP is in charge of all of a patient's care in the United Kingdom, so they have to be informed if anything happens. If you have a DVT or pulmonary embolism in the community, some GP practices are really good at looking after people with clots, so they might do it all themselves. And so we have people like Matt Fay in Bradford who would look after someone's clot himself and do the follow-up. But in most situations, it's hospital clinics that are managing deep vein thrombosis. Any more on this one, Jo?
No. A sort of related one. Have there been any advancements in finding a way to thicken the blood for those who may be in an accident and profusely bleeding while on a DOAC?
So if someone's bleeding profusely, they always get tranexamic acid. Part of all the trials on that, which reduces mortality. And then in the UK, we have a number of drugs that we can use to reverse the effects of DOACs when you get to hospital. So we use the same drug in warfarin as well. It's called PCC. It's available everywhere. And then we've got specific antagonists for different DOACs, which are available in some hospitals. But the PCC works pretty well, so we've relied on it for many years. In actual fact, most people who have a major accident aren't on DOACs, and quite often, because the DOACs are different from warfarin, there isn't often that much of the DOAC around in the blood. So, I mean, how can I put this? If you're on warfarin, your blood is really, really thin 24 hours a day. You do need to be reversed if you're on warfarin. But if you're on a DOAC, after you take the tablet, you get increased levels, and then they start to fall off about 4 to 6 hours. So if you have an accident, say 12 hours after taking a tablet, you might not have that much DIRC around, so it may not make that much difference to your bleeding. So yeah, that's it really.
Okay, brilliant. Yep, that's fine. Thank you. That's excellent.
Anticoagulation. How does my doctor know how long I need anticoagulation? Well, how does anyone really? So if we think about the common causes of anticoagulation, number one, 95% of people who are on anticoagulation have atrial fibrillation, and they need long-term anticoagulation unless the atrial fibrillation is treated. And these days, so atrial fibrillation means you've got an irregularly beating heart, and the atrium doesn't work very well. And the worry for people with atrial fibrillation is the little bit of the atrium, which doesn't work very well, gets a clot forming in it, and that clot breaks up and goes and blocks a blood vessel in the brain. So they have a stroke. So you're taking anticoagulation to prevent stroke in atrial fibrillation. And the use of the DOACs has dramatically helped reduce the rate of stroke that we have in the UK. If you have atrial fibrillation, if you have risk factors, you should be on long-term anticoagulation because it's going to improve your survival. And then we have the rest of the patients. Some have mechanical valves in their hearts and metal valves. They need to be on warfarin long-term whilst they have the valve. And then we have people with DVT and pulmonary emboli, and we've already discussed the fact that if it's a provoked event, you would, oh, my battery is running though, I'm just going to put it in. If you had a provoked event, it would be for 3 months, 3 to 6 months, and if you have an unprovoked event, you will tend to stay on long-term anticoagulation because your risk of recurrent clot is higher. Who have I missed out? Just a second. I've missed out antiphospholipid syndrome. So antiphospholipid syndrome, the care is changing. And for most patients who've had a provoked event, we wouldn't give you long-term anticoagulation, but we would keep an eye on you afterwards. If you've had an unprovoked event, we'd leave you on long-term anticoagulation. We used to say lifelong. I don't say that anymore because I'm aware of some really interesting, exciting treatments coming through. So I still say until something better comes along, because I don't know quite where we're going with antiphospholipid syndrome and whether there isn't some wonderful treatment round the corner. Okay, next, why don't I feel any better after starting this therapy? So I think we're talking here about DVT and pulmonary embolism. And we have to remember that we put people on anticoagulation to stop them developing any more clots. So it's not probably going to make you feel any better. It's going to stop you having a worse problem, but we are reliant on your own body to recover. And so if you have a bad pulmonary embolism, it can take months, many months, to feel better because your lungs are healing and it just takes time. Okay, how do anticoagulants work and what are the different types? So they obviously work by thinning the blood. Warfarin works by antagonizing vitamin K. What does that mean? Well, it stops vitamin K helping to make clotting factors. So vitamin K is needed to make clotting factors 2, 7, 9, 10. And when you take the vitamin K away, because warfarin is counteracting it, then you have low levels of those factors. And then the direct oral anticoagulants, which lots of people are on these days, rivaroxaban, apixaban, edoxaban, well, they're all bans, the bigatran. They work by inhibiting some of the coagulation factors. So rivaroxaban, edoxaban, apixaban, matrixaban, which we haven't got yet, but we might. They all work by inhibiting activated factor 10. Should my anticoagulation dose change if I'm diagnosed with COVID? No, not unless you are admitted to hospital and you have COVID pneumonia. And if you're already on full dose, you're there because the maximum dose we would use would be full dose.
We have a few extra questions that have come in. Can you get a blood clot even when you're taking anticoagulation? What is the likelihood and what would be the warning signs?
So there are a few groups of patients who have really sticky blood who will break through standard anticoagulation. We aren't talking factor 5 Leiden, definitely not. We're not usually talking about those who've got deficiencies of antithrombin, protein C, protein S. It's occasionally patients who have antiphospholipid syndrome who have really sticky blood. And if we run them with on warfarin with a low target of blood thinness. We talk about INR. We might move the INR up from 2 to 3 to 3 to 4. So it's only a very small minority of patients who have recurrent thrombosis and anticoagulation. I'm afraid to say, sitting in hospital as a doctor, the biggest cause of clots on anticoagulation is that people forget to take them, or they're on warfarin and they're not getting good enough blood thinness. Okay.
Can I also ask, somebody's questioned that, is there a recommendation that when you are diagnosed, perhaps in the emergency department, with quite a large DVT, how quickly should you get anticoagulation or even access to thromboprophylaxis? And is there any guidance or is there any training that goes on for all these different departments that may manage that early diagnosis and treatment of the individual?
So the NICE guidelines, so NICE come out with standards of care, say that if you have been diagnosed with a clot, you should be treated immediately. And if you're not sure, but you've got high suspicion, you start treating before you do the scan to confirm the diagnosis. So it should be pretty quick. I mean, we're talking about within hours of suspicion.
Thank you. Slightly related, a little bit off, but somebody's messaged in a question to say that they had multiple PEs 7 months ago. They noticed that their memory was also affected and they thought it might be related to the shock and maybe the anticoagulation, but now they've come off the anticoagulation, they still notice memory loss. They're in their 40s. Is it a known side effect? Is there anything that we know about it or can help with it?
So this isn't something that we normally see with pulmonary emboli. So for that individual, it's not an association with PE. So I think that they need to see their own doctor about that.
And a final one really that's here is that somebody's had a phased return to work after DVTs and PEs following breast cancer. So there was a known trigger for their blood clots. They're on a low dose of a DOAC, apixaban, but they feel absolutely shattered. Would an anticoagulant cause you to feel fatigued, or is it more likely the recovery process?
So most of the anticoagulants don't tend to cause fatigue. It's usually something else. If people aren't sure, then they need to swap over the anticoagulant to another one to see if it might be a funny reaction to an anticoagulant. But anticoagulants don't tend to cause fatigue, no.
Okay, thank you. Yeah, we've answered all the questions so far. Thank you.
I've been told to continue with my anticoagulation for 6 months. Do I need to have a follow-up appointment? So NICE guidance would say that, yes, you need 6 months, and ideally you should be seen once after you have been discharged. But we're very reliant on the body in healing things, and we wouldn't really do anything else in the NHS if you'd recovered well after a clot. And really that is the vast majority of people who've had a clot. And I think that one of the issues that we in Thrombosis UK keep finding is that people just aren't informed enough and reassured enough that they're going to get well after they've had a clot. So we do have some information about post-clot management on our website. How do I know when to seek help for pain and breathlessness? I can't see the rest of it because there's
and when to wait.
And when to wait. So I presume we're talking about chest pain and breathlessness. So if you have, what are the classic symptoms of pulmonary emboli? That you suddenly feel that you're very breathless, perhaps a bit sweaty, and you've got chest pain, which is worse in breathing in, and you don't wait. if you have that, you've had a big pulmonary embolism, you need care. So you'd seek care from the hospital, really. Anything below that, so you gradually are getting more breathless and you've got some chest pain, now and again, I'd try and see a doctor as soon as possible. Very difficult because when I see a patient, I take a full history, I ask all sorts of ins and outs about the pain, which help me decide where the pain is coming from and examine the patient, and we send them off for tests. So I think if you've got unexplained symptoms, you should seek help and from a healthcare professional. This one, at my scan, it was a bit rushed, and after finding my clot straight away, they didn't continue to take rest of leg. Should I have it rescanned? Don't think so, no. I mean, if we're talking about that someone has got symptoms of DVT and they go for a Doppler ultrasound scan and they find a clot in the thigh, then there's no point in taking the scan any further, because you've shown they have a clot and you're going to put them on treatment, and they're going to start anticoagulation as soon as possible. So there's no point in really checking the rest of the leg. It's not going to change how we approach the treatment. Any more questions, Jo?
Just in general, when you have a diagnosis, are there any doctors or nurses that you generally get assigned who may be your touchstone to contact afterwards, like an so if you're on warfarin, you might have the anticoagulation clinic. Yeah. But if you're on a DOAC, is there anybody there that you think often that would be a good person to contact if you have a question?
So, I mean, we have a DOAC clinic and it's run by our wonderful consultant pharmacists, and we have an email address in our clinic for people who want to contact and ask questions, and it would depend very much on the local services that are provided. And I think, Jo, you know, we ought to be talking to NICE as the patient advocate group to say, we get so many people saying they don't have any contact after they have a clot. That's something we ought to take on and campaign about and talk to NICE and see if they can make it a standard of care.
It was a very big topic yesterday in the patient perspective. Yeah. And if anybody wants to see some of that, Sean did share some really good tips on how he kept a diary. So he had something that he could show the doctor of the things that had concerned him. And also to make the most out of his consultation, because he had some notes like you mentioned earlier on. And when he didn't know where to go, he would talk to either his nurse or his GP to find out, what can I do on that one? And having those first points of call really did help. So yeah.
I think, but I do think we keep getting this question. We have to take it up as a campaigning issue, don't we? Because it's quite clear that across the country, there's variable access to healthcare professionals if someone's worried, and a helpline is what's necessary, but locally with someone who knows about their case rather than coming to us and we don't know all the ins and outs of their care.
Definitely.
So thanks for those questions, really helpful. Coping and anxiety. I'm so anxious, I can't stop thinking about it. Is that normal? Yeah, it's normal for some people. And I'm sorry that that's happening, but that's something that we see a lot in medicine. And quite often we're seeing young people who've never been ill, and then they have a clot, or they have something catastrophic like thrombotic thrombocytopenic purpura, which is life-threatening, very rare thrombotic disease. And people often can't stop thinking about it. Why has this happened to me? It's the first time anything bad has happened. Am I going to die? And it's really challenging your psyche and making you think about, am I going to die? And for a lot of people, it's the first time they've ever thought about their own death, because I know we all walk around thinking that we are immortal, and unfortunately we're not. And it's a bit of a shock of the system to come to terms with it. I remember I had a real crisis with it when I became a doctor and I was on the wards and lots of my patients died, and I started to think about death. So just coming back from that, yes, absolutely, some people are anxious, and they perhaps might want to seek some help, visit to the GP, see if they've got any counselling services or cognitive behaviour therapy. The next question, how can I get back a future I feel I've lost? Is there help available? So this is just another expression of this anxiety. And again, you need to seek help. Again, probably through the GP. Even in these difficult times, they still have counsellors and cognitive behaviour therapy available through video conferencing or even face-to-face. So it's to reassure you haven't lost your future with having a clot. And the future really is not that different, I hope, for most people, but it's trying to get back that feeling of well-being and not feeling so threatened.
Can I add, one of our trustees, Professor Paul Bennett, who's a clinical psychologist, has produced about 4 or 5 information fact sheets for the charity, which are on the website, around managing anxiety, panic, positive distraction, all sorts of resources that can really help you recognise that this is very normal, but the strategies that can help reduce this or help you to manage when you feel perhaps a panic or anxiety crisis coming on. We've also, I'm aware of, and has been shared with us a few times, I think NHS Talking Therapist, which is an online service, has also been very helpful for many people and is fairly accessible. So again, there are things out there without having to always wait a long time or seek appointments that can be starting points. But I think, like Beverley said, and Paul always reiterates, is it's really normal to feel this anxious, but there is help there. And if you look at yesterday's recording, there is a future as well.
Okay, since my PE, my speech is not what it was. I am so anxious that I stumble over my words. Is this normal? Is there help available? So it's difficult to know what's going on here. It sounds like it's anxiety. And if it is anxiety, then everything we've talked about so far applies. Post-traumatic stress is very common in people who've had PE and DVT. That's really what we're talking about here. So I would get some help. And I'd also probably have a chat with my doctor and just check that my problems with my speech were brought on by anxiety and that there wasn't a physical cause for it. Okay. Exercise after a blood clot. Is it safe to run with a stent in the iliofemoral vein? So we do lots of stenting, and we would hope that our people who had stents got back to their normal life. And if they were runners, we would expect them to run. So what do we mean by a stent? I mean, it's like a piece of chicken wire that you'd put inside a vein that's collapsed down and was full of clot. Take the clot out and put the chicken wire in there to keep the vein open. So yes, you should be doing what you used to be doing. If your vascular surgeon says it's fine. I am still breathless. Is this because of the PE or because I am 70 and I do no exercise? So I don't know who did this question, but I don't know. And the way of finding out would be to do some more exercise to see if you get that little bit fitter. If you're still breathless after a lot of exercise, again, I'd seek medical help. Occasionally, people who've had blood clots don't dissolve them all, and they're left with quite a few, which do make them a little bit breathless, but this is very rare. So I think the most likely thing is to get a bit of exercise and see if the breathlessness improves first.
Saying that last bit, Beverley, a question's coming about, is it usual to be rescanned after you complete your anticoagulation therapy to see if it's gone? To see if the scan is
No. So we don't normally rescan. We have to remember that normal scan is called a CT pulmonary angiogram, and it's giving a big dose of X-ray. So we will use it to diagnose, but there's little point in looking at residual thrombosis because it's not going to change the management of the patient. If they're less breathless and back to normal living, they've dissolved enough of the clot to get back to normal. So we wouldn't tend to. It's only if people had continuing symptoms that we would have another look. Pain. Why do I have pain in my legs 6 months after diagnosis? So if you have a big deep vein thrombosis, you can be left with what we call post-thrombotic syndrome. And that covers having residual pain and swelling and skin rashes and getting new varicose veins, and in the worst case scenario actually getting a leg ulcer. So it sounds like if you have pain after 6 months, you probably need to see a vascular surgeon to see whether you have post-thrombotic syndrome. Is DVT rehabilitation available for people who have been diagnosed with a DVT? No, we don't think that everybody needs it. So the body's very good at healing. And so we don't normally give rehabilitation to people after DVT and pulmonary emboli. They tend to get better pretty quickly on their own. There is a minority who might benefit, I guess, but we're just not in that place to offer it. Last one, I can walk for 30 minutes daily without any pain, but I struggle to do food shopping and gardening without suffering pain for a day or two on my right hand side of my chest, arm and neck. Is this normal? So we don't know anything about this individual, about whether they've had clots before. And I can't answer that question because there's just not enough information there to know what's going on. Sorry, I can't help. And I think that this person needs to go to their general practitioner. We have to remember that a lot of pain that we get from day to day is musculoskeletal. So I honestly can't say. There's not enough information. Sorry.
That's okay, we can follow that up and let them know. Somebody has also put in a comment that they suffered a serious DVT 20 years ago. And so they found for them, compression stockings were invaluable to avoid ulcers and other problems. Have there been any advances in this? Because obviously there have been some trials about other links with compression stockings, as there seems to be more emphasis on anticoagulation as treatment. But is there any news or update or anything that people should be aware about?
Fantastic, thanks for that question. So we used to, when people had a clot up to about 5 years ago, give everybody a tight pair of stockings. And when you come into hospital, you get what we call anti-embolic stockings to compress the legs. And the stockings we use after someone has a clot are that much tighter, and they give more compression than the hospital stockings. And we used to do that because we believed if you wore stockings from the day you had the clot, and you did it for at least 6 months, then you would reduce the risk of post-thrombotic syndrome. But there was a trial that was done in the States that suggested there was no benefit at all in reducing the risk of having post-thrombotic syndrome. So we stopped doing that. Now, that trial has lots of faults in it. So in the UK, we are asking that question again, and we have a study which Thrombosis UK supports and which I'm very much involved with, called the CHAPS study, which we're just starting. Alan Davis, the professor of vascular surgery at Imperial, is leading on it. And we are seeing people with fresh deep vein thrombosis in multiple hospitals across the UK, and we're randomizing them to having a pair of tight stockings to not having a pair of stockings, which is standard management, to look at the question again, and we're following these patients up very closely. So we don't know, we're not clear that they do reduce the risk of post-thrombotic syndrome, but if you have post-thrombotic syndrome and you have a lot of swelling in your leg, then the stockings are really useful to reduce the swelling. And so we find that people with post-thrombotic syndrome, at the beginning of the day, they might have quite a small ankle, and then as they stand on the leg during the day, because the veins are so poor, taking the blood out of the foot and the ankle, that the ankle starts to swell, and then the calf starts to swell, and even the thigh will swell. So a pair of stockings on that type of leg is quite effective in reducing swelling.
And something which is associated with really after VTE, and somebody's asking, one or two people have asked about this, is sometimes they've suffered balance issues after a PE. Is that normal or recognised? It's a constant feeling of veering to one side, or should they probably go and talk with their medical lead?
I think that's suggesting there's something wrong in the brain rather than due to PE. So I think, again, they need to see the healthcare professional.
Okay, thank you. I think on the pain side, we've covered all the ones we've had submitted. Thank you.
Okay.
Last slide.
So updates and new options. I've lived for 20 years with occluded IVC, inferior vena cava, and poor circulation that has resulted from it. Is there any new treatment now available that might help? I work with Stephen Black, who's a vascular surgeon at St. Thomas's, and we do a lot of stenting, and they do the same in most of the big cities in vascular surgical units. And what stenting does is, if you're suitable for it, and it's only a minority who are suitable for it, would be to remove the clot, as I said before, and then to put some support in the vein to keep it open, and to leave patients on anticoagulation while the stent settles, to see if you can get some improvement in getting the blood up out of the lower body. So what that requires is a referral to a vascular surgeon who specializes in it. Then they would do some imaging to look at the state of the veins. We tend to use magnetic resonance imaging, eject dye and pick it up with magnetic resonance, which has got much less exposure to X-ray, obviously, than doing CT. And then if something was amenable to stenting, they'd have a discussion with the vascular surgeon and have a date to come into hospital and to have the procedure. Now, this is all new. This has been going on about 5 years. We've looked at our 2-year figures, and there's about a 75% rate of the stents staying open after 2 years. But that's only 2 years. We have a minority where it all clogs up again because the flow never got to be very good. So I would regard it somewhat as an experimental procedure. So if you did have long-term problems, get a referral, be a little bit skeptical, and talk to the vascular surgeon about how might I be in 5 years. But if things are really bad, you haven't got much to lose, it might be worth the option. There are some complications, so patients can bleed, they can rethrombose again, they might need the stent reboring and doing the whole operation again in a couple of weeks. So it's not without its complications, but it is starting to improve. I think the major improvement has been that in the last 5 years, instead of using a stent that was designed for an artery, stenting started in the heart attack people, to put a stent in a coronary artery after they'd removed the clot. We aren't using arterial stents anymore. We're using special venous stents that are very rubbery and will move around, they're not so stiff, and they'll move with the body. But it's new technology. New technology will always have teething problems, so that has to be borne in mind. Right, next question is there any more up-to-date advice that could help maintain a healthy life as I am now in my 60s? My darling, you're in your prime and just enjoy life. I mean, the average life expectancy in this country is something between 82 and 84. So it's the usual stuff that you would say to anybody: regular exercise, at least 30 minutes walking a day. I say to my stepmom and everyone I know who's in their 70s or 80s, and good diet, stay slim, don't smoke, a little bit of alcohol, have your blood pressure checked every year, and there's no reason why you shouldn't carry on for quite a while.
Thank you, Beverley. There's a few questions that have come in that cover quite a number of different areas, but so if I can go through those with you. One is about a PE. How do they know whether it was provoked or not? They do have a family history of protein S deficiency, but they've already had 2 children without any problems. Suddenly they developed a PE. What they do add, though, is that they did spend a lot of time sitting down during lockdown.
There you go. What do you want me to say? So I think, but the other thing that we haven't talked about is as you get older, your blood gets stickier. So if you have protein S deficiency and then you've had 2 babies at a young age, your blood gets sticky whilst you're pregnant and you've got the protein S deficiency, but everything's okay. And then you have a clot later on. It's a warning to say, get moving, really. And I think some people would probably leave that individual on long-term blood thinners, and other doctors would say, if you look after yourself and you keep mobile, and if you're overweight, lose weight and reduce all the other risk factors, then you wouldn't need long-term blood thinners for the moment. It's a difficult one, that one.
A question about risk factors. So would something like a celiac disease also count as a risk factor due to the inflammation or autoimmunity?
Sorry, a what?
Would something like, and I'm hoping I'm a celiac disease also count as a risk factor due to inflammation or autoimmunity?
Okay, so it's a good question, that one, because if you've got celiac disease and you follow your celiac diet, you won't have any increased inflammation, and you're just a normal individual, so you wouldn't have increased risk. Whereas if you have got celiac disease and you eat all the wrong food, there will be a lot of inflammation in your bowel, and that will tip over into the blood and cause sticky blood, so that would cause increased inflammation. So it's really following your diet and staying healthy that's required.
Okay, thank you. 2 questions are linked to APS. Do you think there's a link between APS and a diagnosis of a bilateral temporal hypometabolism? Crumbs, I'm useless at this thing. Hypometabolism. Thrombophilism. Why can't I say these words? Link between that. Is there anything known?
Lots of people with antiphospholipid syndrome say they have a fuzzy head, especially if they've had a previous stroke, and they often feel better on a high dose of warfarin, maintaining an INR of 3 to 4. Some of us have been doing some more research and looking at metabolism within the brain in people with antiphospholipid syndrome. None of it's published, and it needs to be done so, and found that there is reduced metabolism in the temporal lobes in occasional patients with antiphospholipid syndrome. And nobody quite knows what the best treatment for that is, but some immunosuppression has been offered. Now, whether that's part of antiphospholipid syndrome or whether that's something totally different or whether it's another autoimmune disease, I don't think we know. And so it's right at the edge of research, and people need to start doing a bit more research in that area.
Thank you. And somebody has also said that after they had extensive clotting, they were suspected of having APS, but extensive multiple blood tests didn't confirm this. They can't think of another reason why they had such a bad unprovoked clot. So I guess the two questions in that is, could they still have it? But also, would their treatment be any different, or would there be anything they should be aware of?
So sometimes you have patients and they have the most awful clots and you don't have any underlying diagnosis, but you say, my goodness, they've got sticky blood, and you treat them as though they've got bad antiphospholipid syndrome. And I think that's the way life is. It's not nice not to be categorized as something. There are other conditions, a little bit like APS, that can cause very sticky blood. But again, the treatment is to give high dose anticoagulation in the long term to stop them having future clots. So does that cover it? It's not entirely satisfactory. And sometimes you see a patient and they might be called Edward or something like that, and you do everything you possibly can. You can't find the cause, but you and Edward accept they've got Edward's disease, and that's sticky blood, and hey, we're going to give you lots of anticoagulation in the future to keep you well.
Okay, thank you. And then the last question, which is on a topic we haven't really touched on so far today. This person has had 2 episodes of thrombosis, and their CT scan shows pulmonary hypertension. Is there a link? Why is this?
Okay, so we can get chronic thromboembolic pulmonary hypertension. That's what we call it. It's far too big a word. So what are we talking about there? We're talking about the fact that many of the arteries within the lung have been blocked with clot, and they're so blocked with clot that their blood dams back into the right side of the heart, which is meant to push the blood on through the heart, and it's finding it hard because you've blocked most of the arteries. So it has to generate higher pressures to push the blood through the lungs. And so that higher pressure in the right side of the heart is known as hypertension. It's pulmonary hypertension. So there are many units really interested in this. The fact that this individual knows they have it suggests they're under the care of a special unit who will offer them state-of-the-art treatment. I think we're pretty good as a country in managing this condition, and it can be managed medically with tablets, and some patients might end up having surgery where all of those excessive clots are removed. We only have one hospital in the UK that does this surgery. It's Papworth, and we only have one hospital, so it's a very difficult operation to do, and it's got a mortality attached to it. But they are skilled, and that's really the surgeons who attach that unit just tend to do that operation, so that they're really highly skilled to get the best outcome for those patients. So we do refer patients who might benefit from surgery to Papworth, but most people who have pulmonary hypertension don't need that. They just need a few extra drugs to make them feel a bit better.
Beverley, you're amazing. Thank you so much. We have used, I've lost count of the questions, both those that was pre-submitted and came in during this morning's discussion. So thank you so much. Is there anything else you wanted to add? Or?
I think the way I explain things often generates more questions than answers. So Jo, you're going to have to tell everyone where they go to, or we do this again with more specific questions.
Mm-hmm. We will say the recording will be there, and we will contact everybody who joined today with signposting to other information and resources that may give further information or help on this as well. For now, though, thank you so much, Beverley. Thank you to everybody who joined today.